So I've been talking about the nursing process in all my lectures as I've been going along. So now we're actually going to go more in depth about the actual process itself. The nursing process is actually a critical thinking framework that involves assessing and analyzing human responses to a plan and then implementing nursing care that meets the patient's needs. And then once we get done implementing, we're going to evaluate our outcomes. Nurses use critical thinking throughout the nursing process, which involves both thinking and doing to meet complex patient needs. Assessment, the first step of the nursing process, is the ongoing systematic collection, validation, and documentation of data. Nursing assessment should be comprehensive, holistic, and accurate, so it provides all the necessary information about a patient. In addition, it should reflect the patient's response to a health problem and stressors, not just the disease processes. Adequate assessment depends on collecting data using various methods, collecting both subjective and objective data, verifying that the data is accurate, and communicating information about assessments to other members of the healthcare team. There are several different types of nursing assessments. The initial assessment is performed shortly after admitting a patient to a healthcare facility. It's performed to establish a complete database for problem identification and care planning. It's performed by the nurse to collect data on all aspects of the patient's health. A focused assessment may be performed during the initial assessment or as a routine ongoing data collection. It's performed to gather data about a specific problem already identified or to identify new or overlooked problems. It can be performed by the nurse to collect data about a specific problem. A quick priority assessment is a short, focused, prioritized assessment that's completed to gain the most important information needed first. An emergency assessment is performed when a physiologic or psychological crisis presents. It's performed to identify life-threatening problems. A time-lapsed assessment is performed to compare a patient's current status to their baseline data that was obtained earlier. It's performed to reassess health status and make necessary revisions in the care plan. Triage is a screening assessment to determine the extent and severity of a patient problem and recommend appropriate follow-up. It can be completed on the phone or in person. Triage nurses need highly specialized nursing knowledge and clinical reasoning and judgment skills in order to perform safe triage. A patient-centered assessment method, or PCAM, is a tool used by healthcare practitioners to assess patient complexity using social determinants of health. It helps to ask questions to gain understanding about the patient's health and well-being, social environment, health literacy, and communication skills. So let's talk about the different methods of data collection. One of the first methods is the physical exam. We're going to use the inspection, auscultation, percussion, and palpation to collect data about the patient's health status. Next method would be interviewing, and interviewing can be formal or informal. A formal approach is used when collecting information in a prescribed or an official way, such as for a history and physical. Usually involves asking direct rather than open-ended questions. An informal approach is used when collecting data in a casual and more relaxed way, such as when exploring a patient's feeling about while providing other nursing care. So when you're talking to the patient when you're giving them a bath, and you can get a lot of information that way. Informal usually involves open-ended questions. The other method we can get data from regarding our patient is the clinical record. This involves monitoring information collected about the patient in the electronic medical record. It gathers information about results of lab exams, diagnostic procedures, consultations by other members of the health team, and progress notes. There are actually 3 different sources of data. You have primary, secondary, and tertiary sources. The primary source of data is the patient. Okay? The patient is the only primary source of data. The patient is the most valuable source because the data collected is the most recent, unique, and specific to the patient. A secondary source, these sources provide supplementary information about the patient from someplace other than the patient, but within the patient's frame of reference. They include people other than the patients, so like family members, friends, or other health team members. A patient's clinical record is also a secondary source, as it contains a vast amount of information about the patient's physical, psychosocial, and economic history, as well as information about the patient's progress regarding physical and emotional responses to a health problem. The last source is a tertiary source. These sources produce data from outside the patient's frame of reference. So an example of this would be from like textbooks, surveys, medical and nursing journals, drug books, policy and procedure manuals, anything that you're using to help take care of the patient, but it's not necessarily about the patient. There are two different types of data. There's objective data and subjective data. When we look at objective and subjective, also think signs and symptoms. So when we're talking about patients and we talk about signs and symptoms, our objective data are the signs. Subjective data are the symptoms. So objective, this is overt, measurable assessments collected via the senses. So sight, touch, smell, or hearing. And then we compare it to an accepted standards. So examples would be body temperature, pulse ox, respiratory rate, blood pressure, vomiting, a distended abdomen, presence of edema, lung sounds, crying, skin color, presence of diaphoresis. This is all stuff that we can see and measure, so it's objective. Subjective is covert information. This is feelings, perceptions, thoughts, sensations, or concerns that are shared by the patient and can be verified only by the patient. So examples of this would be itching, nausea, pain, numbness, attitudes, belief, values, and perceptions of the health problem and life circumstances. So after we collect all our data using our assessment, then all that data must be double checked or verified. This helps ensure the validity and the accuracy of the data. This also helps ensure that we as nurses don't come to a conclusion without adequate data to support the conclusion. This may involve collecting additional information to help support the initial data. So for example, if a patient's pulse is increased above an expected range, the nurse should take the pulse again. If it's still increased, the nurse should collect other vital signs to supplement the original information. Verifying the data also helps to identify whether objective and subjective data are congruent or if they're incompatible. So an example of this, when a patient has an increased blood pressure, pulse, and respiratory rate and is rubbing a shoulder, the nurse may make an inference that the patient is experiencing pain. So to validate this, the nurse is going to ask, so I noticed you're rubbing your shoulder. Is it causing you any pain or discomfort? Or another example would be if the patient says, man, I feel like my bladder is going to burst. The nurse can make the inference that the patient might be experiencing urinary retention. To validate that, the nurse should palpate the patient's abdomen for distension. The nurse can also ask questions that clarify the patient's statement. So once all the data is collected and verified, it needs to be communicated to various sources. So all the outcomes of the nursing assessment must be documented. It needs to be documented on correct forms and in appropriate places in the patient's clinical record. Communicating data ensures that important information is shared with other health team members. The data also must be communicated in an objective way. We must document facts and not just be in a summary of our opinions or our interpretation. We want to avoid value words if we can. So words like good, bad, adequate, poor need to be avoided. So for example, rather than saying that a patient's appetite is poor, the nurse should document that the patient ate half of a scrambled egg and a slice of toast. This way of documentation communicates objective, measurable information about the patient's appetite. Value words related to a patient's behavior should also be avoided, like lazy, difficult, stubborn, rude. These words reflect a value judgment made by the nurse, and that can be influenced by our own personal bias or our personal beliefs. Subjective data should be documented in exact words with quotation marks. So this practice helps ensure that the patient's meaning is not misinterpreted or inaccurately altered by words that are used by the nurse. Diagnosis or analysis, the second stage of the nursing process, requires the nurse to use critical thinking strategies to scrutinize data. Activities associated with this step include clustering data, interpreting data, and identifying and communicating a patient's nursing diagnosis, problem, or need. Okay, so I like this slide in the fact that it kind of gives you a visual of what kind of steps we've been taking. So that first box kind of shows the assessment step, and that's everything that we talked about earlier. The next two boxes are the diagnosing and analysis steps. So we're going to take all the information that we collected in that green box, and then we're going to analyze it, synthesize it, reflect on it, and then we're going to draw some conclusions, and then start that diagnosis phase. So we're going to start listing, we'll take all this information and we'll create a list of suspected problems. We'll rule out any problems that we need to think about. Name actual problems or potential problems, risk factors, identify resources and strength. That's all part of this diagnosis analysis stage. Most experienced nurses begin the work of interpreting and analyzing data while they're still collecting the data. Significant data should raise a red flag for the nurse, who then looks for patterns or clusters of data that signal an actual or potential health problem. So let's talk about the steps needed to interpret and analyze collected data. Sorting out healthy patient responses from those that are not healthy is not as clear-cut as it may seem. To avoid mislabeling a selected patient health pattern as unhealthy, while failing to detect an actual unhealthy behavior, nurses must be familiar with comparative standards to be used in data interpretation and analysis. For example, the example that was given in your book is blood pressure readings. If you have a patient whose blood pressure is 150/90 and they normally run 120/70, then the reading you obtain is out of their normal standard. It is also considered out of range per the standards of the population, which we know means that readings above 140/90 are considered high. A data cluster is a group of patient data or cues that point to the existence of a health problem. You will be collecting a lot of assessment data on your patients, so it's important to cluster information together in order to identify pertinent problems. The next step in analyzing data is to determine the patient's strengths and problems. It also helps to determine whether the patient agrees with the nurse's identification of strengths and problems and is motivated to work towards problem resolution. Patients' strengths might include healthy physiologic functioning, emotional health, cognitive abilities, coping skills, interpersonal strengths, and spiritual strengths. Resources such as the presence of support people, adequate finances, and a healthy environment may all contribute to a patient's strengths. You need to identify a patient's potential problems or weak areas in order for them to meet the goals you are trying to establish. An example would be that you are trying to discharge an elderly patient home, but you find out that they live by themselves and that they have no one to help them manage their diet, medications, and new therapies. You will need to refer them to outside resources for support, or they may very likely end up back in the hospital. Patients may experience many complications related to their diagnoses, medications, or treatment regimens, or invasive diagnostic studies. For example, slurred speech, changes in skin color or moistness, inability to move an extremity or abnormal movement, or changes in level of consciousness may all be indications of a serious and life-threatening complication. Remember, if you are unsure about the significance of some data, always confer with somebody else who has more experience. So now the nurse is basically going to reach one of three basic conclusions after interpreting and analyzing the patient's data. Different nursing responses result from each conclusion. So we may decide that there's no problem at all. If that's the case, then there's no response needed from us. We're just going to reinforce the patient's health habits and patterns that they're already doing. We may initiate health promotion activities to help prevent disease or illness or to promote a higher level of wellness. We might reach a conclusion that there's a possible problem. If we think there's a possible problem, we probably don't have enough data yet. So we may need to go and collect more data to confirm or disprove that there's a suspected problem. And then the last conclusion would be an actual or a potential nursing diagnosis. In this case, we're going to document the diagnosis, the problem, or the issue, and then begin planning, implementing, and evaluating care designed to help prevent, reduce, or resolve a problem. We may need to consult with the appropriate healthcare professionals and work collaboratively, depending on what the problem is. And if we're unable to treat the problem because the patient denies the problem and refuses treatment, make sure that the patient understands the possible outcomes from this. So let's talk a little bit about the difference between nursing diagnoses or nursing problems versus medical diagnoses. Medical diagnoses convey information about the signs and symptoms of disease processes and provide convenient means for communicating treatment requirements. The physician focuses on treating the underlying pathology. In contrast, a nursing diagnosis describes an actual risk or wellness human response to a health problem that nurses are responsible for treating independently. Nursing diagnoses describe the patient's response to the disease process, developmental stage, or life process, and provide a convenient way to communicate nursing therapies and interventions. So an example of this would be pneumonia. Pneumonia is considered a medical diagnosis. It has an ICD-10 code, which is a diagnosis code that can be used to get reimbursement from Medicare and insurance companies. On the other hand, ineffective airway clearance is considered a nursing diagnosis. Remember, a nursing diagnosis describes a human response to a health problem. Since pneumonia usually causes a lot of thick secretions in the airway, the human response is ineffective airway clearance. There are 3 different types of nursing diagnosis. Actual or risk for problems are the most commonly used in the hospital setting, and then health promotion or wellness diagnosis are used more in the public health setting. And we're going to talk about all of these. A patient problem present during a nursing assessment is known as an actual or a problem-focused diagnosis. Generally, the problem is seen throughout several shifts or a patient's entire hospitalization. However, it may be resolved during a shift depending on the nursing and medical care. Actual or problem-focused nursing diagnoses are typically based on signs and symptoms present in the patient. They are the most common nursing diagnosis and the easiest to identify. Examples of this type of diagnosis include decreased cardiac output, chronic functional constipation, impaired gas exchange. A risk nursing diagnosis applies when risk factors require intervention from the nurse and the healthcare team prior to a real problem developing. This type of diagnosis often requires clinical reasoning and nursing judgment. Examples of risk-type nursing diagnosis include risk for imbalanced fluid volume, risk for ineffective childbearing processes, risk for impaired oral mucous membrane integrity. The goal of a health promotion nursing diagnosis is to improve the overall well-being of an individual, family, or community. You would more likely use these types of diagnoses in a family practice or a community setting. But examples of this would be readiness for enhanced family processes, readiness for an enhanced hope, sedentary lifestyle. Now, back in the day, a nursing diagnosis had to have several parts listed within it. This included the diagnostic label, related to factors, and defining characteristics. As nursing education has evolved, we are moving away from full-blown nursing care plans and to concept mapping and the identification of nursing problems. So when talking about nursing diagnoses, we are just going to focus on the diagnostic label and descriptors. So the diagnostic label describes the essence of the problem using as few words as possible. So some examples include altered skin integrity, fluid overload, grief, and risk for falls. Each nursing diagnosis or nursing problem represents all of the data that was collected, clustered, and interpreted during the assessment phase of the nursing process. Descriptors or modifiers are words used to give additional meaning to a nursing diagnosis. They describe changes in conditions, state of the patient, or some qualifications of the specific nursing diagnosis. Let's use one of the nursing diagnoses from the previous slides. So let's say we have a patient whose assessment shows that they are grieving. So we use the diagnosis grief. However, maybe it's been 5 years since the death of their loved one and they still can't leave the house or make it through a day of work without crying. We may need to add the descriptor dysfunctional or complicated. So the diagnosis for this patient would be dysfunctional or complicated grief. This is just a small list. The slide just shows a small list of descriptors that you may use. Don't think that you have to use just those that are on the list. Planning, the third step of the nursing process, provides direction for nursing interventions. It is concerned with identifying priorities, establishing goals and expected outcomes, and selecting nursing interventions that will help the patient achieve these goals and expected outcomes. Planning begins when the patient is admitted and is ongoing to meet the changing or emerging needs of the patients. Effective planning includes collaboration with all appropriate healthcare team members and to facilitate continuity of care in a patient-centered, individualized, and coordinated manner. Planning culminates in a document about the proposed plan of care that is communicated to all members of the health team. In acute care settings, 3 basic stages of planning are critical to comprehensive nursing care: initial, ongoing, and discharge. In other settings, such as long-term care, hospice care, or community clinic, initial and ongoing planning may be the primary types of planning. If a nurse develops a comprehensive plan of care on the patient's first day but fails to update the plan will not be effective or efficient. Initial planning is performed by the nurse with the admission nursing history and the physical assessment. This comprehensive plan addresses each problem listed in the prioritized nursing diagnoses and identifies appropriate patient goals and the related nursing care. Ongoing planning is carried out by any nurse who interacts with the patient. Its chief purpose is to keep the plan up to date to facilitate the resolution of health problems, manage risk factors, and promote function. The nurse caring for the patient uses new data as they are collected and analyzed to make the plan more specific and accurate, and therefore more effective. The work of ongoing planning includes stating nursing diagnoses problems more clearly, developing new diagnoses and problems, adjusting patient outcomes to be more realistic, developing new outcomes as needed, and identifying nursing interventions that will best accomplish the patient's goals. Discharge planning is best carried out by the nurse who has worked most closely with the patient and family, possibly in conjunction with a nurse or social worker with a broad knowledge of existing community resources. In acute care settings, comprehensive discharge planning begins when the patient is admitted for treatment, or even before admission. Careful planning ensures that the nurse uses teaching and counseling skills effectively to help the patient and family develop sufficient knowledge of the health problem and the therapeutic regimen to carry out necessary self-care behaviors at home competently. To develop a prioritized list of nursing diagnoses or problems, the nurse needs guidelines for ranking diagnoses as high, medium, or low priority. High priority diagnoses pose the greatest threat to the patient's health and well-being. Diagnoses or problems that are not life-threatening are ranked as medium priorities, and diagnoses or problems that are not specifically related to the current level of health or well-being are of low priority. There are certain theoretical bases that we can use to promote the prioritization of patient care. Maslow's hierarchy of needs is one of them. These needs are placed in order from the most basic needs to the highest level needs. So it starts out physiologic needs, then safety, love, belonging, self-esteem, and self-actualization in that order. We also need to look at the urgency of the health problem. Ranking by urgency ranks problems based on the degree of threat to the patient's life. Think ABCs, airway, breathing, circulation. A high priority problem poses the greatest threat and should be addressed first. So, for example, would be an impaired airway. A medium priority problem follows a high priority problem. It may be related to a harmful physiologic response that are not an immediate threat to life, so like impaired mobility. A low priority problem should pose the least threat and be ranked last. It may require minimal support, like nausea. We also need to look at the patient's priorities. This ranks patients' needs based on what is most important to the patient. Now, although a patient's preference should always be taken into consideration, basic life-threatening needs require urgent interventions and override any less important needs, which includes the patient's preference. We also need to look at the future impact of the patient's condition. Although a problem may not be life-threatening and is not recognized by the patient as important, the nurse may determine that it can cause future negative consequences if not addressed. So for example, a nurse identifies that a patient newly diagnosed with type 1 diabetes has dirty feet and is wearing sandals instead of shoes that enclose the feet. The nurse knows that people with diabetes are at risk for foot problems secondary to impaired circulation to the lower extremities. Therefore, the patient has a potential for skin breakdown, which can lead to an infection or even an amputation. The nurse ranks this issue as priority and plans interventions to educate the patient about foot care. In the planning stage, outcomes are derived from the nursing problem. For each problem in the care plan, at least one outcome should be written that, if achieved, demonstrates a direct resolution of the problem statement. Outcomes may be either long-term or short-term. Long-term outcomes require a longer period, usually more than a week, to be achieved. They also may be used as discharge goals, in which case they are more broadly written and communicate to the entire nursing team the desired end results of nursing care for a particular patient. So in this case, on this slide, if you look at this, so our first problem statement is pain. So the goal is within 8 hours, the patient will report pain is absent or diminished. Another problem we found with this patient, we've got a nutrition problem, more than body requirements. So within 2 weeks, by a specific date, the patient will reach a target weight of 122 pounds. And then the last problem we have is an impaired physical mobility. So the outcome for that, before discharge, the patient will ambulate length of the hallway independently. So when writing our goals and our outcomes, we need to kind of think, there's some specific criteria we need to think about. Our criteria starts with our goals and outcomes need to be patient-centered. So the patient is the center of the health team, therefore the patient should be the subject of all goals and outcomes. So for example, the patient will transfer from the bed to the chair safely within 1 week. That's patient-centered. Our goals and outcomes need to contain an action verb. The goal or outcome should identify the action that the patient will learn, do, or verbalize within, or the physical status the patient will attain. So for example, the patient will transfer from the bed to the chair safely within 1 week. That's the action verb, is transfer. It needs to have a performance criteria. So actions must be specific and measurable. For example, the patient will transfer from the bed to the chair safely within 1 week. Conditions may be included to describe the kind of assistant or resources that the patient needs. So for example, the patient will transfer from the bed to the chair safely with a one-person assist within 1 week. It's still all about the patient, but we have measurable criteria for that. Then it needs to have a time frame. The goal must be achievable within a set time frame. So example, the patient will transfer from the bed to the chair safely within 1 week. Additional examples of time frames include by discharge, within 24 hours, at all times, and will maintain. The word maintain implies that it's going to be continuous. Our goals and outcomes need to be realistic. The performance criteria identified must be reasonable and feasible in light of the patient's emotional and physical status. Goals are realistic when the outcomes can be achieved in the indicated time frame. So an example of a realistic outcome for a patient who had abdominal surgery is the patient will exhibit bowel sounds within 3 days after surgery. Example of an unrealistic outcome for a patient with hemiplegia due to a stroke is the patient will perform active range of motions exercises independently within 1 week. That's not realistic for somebody who's paralyzed on one side. So this is a very important concept about goals and outcomes. Patients and nurses together should set goals and outcomes to ensure that these goals and outcomes are realistic, achievable, and in alignment with what the patient and the nurse want to achieve. As nurses, we may have all these grand ideas about goals and outcomes and all this stuff, but if our patient doesn't agree with it, then it's not going to happen because they're not going to work with us. So the other part of the planning process is to identify nursing interventions. We want to identify nursing interventions that are going to help us meet our goals that we established. If the data you collected during your assessment isn't accurate or thorough, you may not see any improvement in your patient's condition because you may not be addressing the priority problems, or your interventions will not be effective because you didn't identify the correct problems. The scientific rationale is the justification or the reason for carrying out the intervention. The rationale is the why of the intervention, and it describes a research-based reason for performing the intervention. On your concept maps for clinical, you are required to supply scientific rationales to show the understanding of the basic reasons for carrying out specific nursing interventions. A reference for each scientific rationale may be given, citing the author, year, title, and page of the article or the book used. And we'll talk more about this in class. So there are 3 types of nursing interventions that we're going to talk about. They're independent or nurse-initiated, dependent, and interdependent or collaborative. So registered nurses can legally order and implement independent nursing interventions without the supervision or direction or an order from a person with a prescriptive license. Each state's Nurses Practice Act defines the scope of nursing practice within the state. Some examples of independent nursing interventions include assessment, nursing diagnosis of a patient's nursing needs, planning, implementing, and evaluating nursing care, assisting with ADLs, teaching any subject associated with health promotion and illness prevention, counseling, advocating for a patient, encouraging coughing and deep breathing, and referring a patient to community resources. Dependent nursing interventions require an order or prescription from a healthcare professional with prescriptive privileges. This can include physicians, podiatrists, physician assistants, and nurse practitioners. Nurses must ensure that the ordered interventions and prescribed medications are appropriate to meet the needs of the patient. If a nurse implements an inappropriate order or prescription, the nurse can be held legally accountable as a contributor to the initial error made by the primary healthcare provider. Nurses must question inappropriate orders or prescriptions and not follow them blindly. So examples of dependent nursing interventions: administering medications or IV solutions, implementing activity orders, inserting or removing a urinary catheter, providing a specific diet, or implementing wound or bladder irrigations. Nurses work in collaboration with primary health care providers to implement dependent nursing interventions when we talk about interdependent nursing interventions. In some settings, such as the ICU and birthing units, they have standing orders or protocols, and these help delineate parameters in which a nurse can implement a dependent nursing intervention. So an example would be in the ICU, if you've got a patient that's on an insulin drip and they're doing hourly AccuChecks to figure out where their blood sugar falls, there are standing orders that say, okay, if you got a patient that's got a blood sugar between 400 and 450, we're going to increase the insulin drip by 2 units. That's a standing order, but it's considered interdependent because the nurse has to make some judgments in regards to that. Other interventions that interdependent nursing interventions that you may see, maybe they'll see an order in the patient's chart that says out of bed as tolerated. The nurse is going to determine whether the patient is tolerating an activity and therefore the amount of activity in which to engage the patient. The patient is also involved in this as well, because the patient's going to let the nurse know if they're not tolerating something very well. So an interdependent nursing intervention involves the prescriber, the nurse, and the patient. Another example of an interdependent nursing intervention involves PRN or as-needed pain medication. So we've got a prescription for pain medicine that states Tylenol 650 milligrams every 6 hours for mild lower back pain, PRN. The nurse is going to assess the patient's level of pain and then decide whether or not to administer the prescribed dose. And the patient's going to rate their pain and let the nurse know where their pain is sitting. So it's interdependent. Implementation, or the 4th step of the nursing process, is the actual performance of nursing actions. It is the execution of the plan of care and involves thinking and doing. Therefore, nurses must not only have a strong knowledge base of sciences, nursing theory, nursing practice, and legal parameters of nursing interventions, but they also must have the psychomotor skills to implement procedures safely. Nurses must implement only nursing actions that are described in their state's Nurse Practice Act and conform to professional nursing standards of care. In all nurse-patient interactions, the nurse is concerned with the patient's response to health and illness and the patient's ability to meet basic human needs. Doing this involves 3 areas: scope of practice, nursing intervention, taxonomy structure, and care coordination and continuity. Scope of practice describes the services that a qualified health professional is deemed competent to perform and permitted to undertake, in keeping with the terms of their professional license. The American Nurses Association states that the nursing scope and standards of practice describe the who, what, where, when, why, and how of nursing practice. The who, registered nurses and advanced practice registered nurses, comprise the WHO of constituency and have been educated, titled, and maintain active licensure to practice nursing. What? Nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and injury, facilitation of healing, alleviation of suffering through the diagnosis and treatment of human response, and advocacy of the care of individuals, families, groups, communities, and populations. Where? Where there is a patient in need of care. When? Whenever there is a need for nursing knowledge, compassion, and expertise. Why? The profession exists to achieve the most positive patient outcome in keeping with the nursing social contract and obligation to society. When we talk about nursing intervention taxonomy structure, the Nursing Intervention Classification, or the NIC, is a report that was published that classifies and standardizes nursing interventions. This report is designed to develop a common nursing language that optimizes the design and delivery of safe, high quality, and cost-effective care. One of the nursing's major contributions to interprofessional healthcare team is the role of coordinator. Care can easily become fragmented when patients are seen by numerous specialists, each interested in a different aspect of the patient and in different settings. It is important that nurses make rounds with other healthcare professionals and to read the results of consultations that patients have had with specialists. They can then interpret the specialist's findings for patients and family members, prepare patients to participate maximally in the care plan in both institutional and community settings, and serve as a liaison among the members of the healthcare team. As you implement the plan of care, you are constantly engaging in clinical reasoning and judgment about what you are doing. Since patient conditions can change dramatically in minutes, you must reassess the patient for changes in status that may dictate a different set of interventions. You also want to be sure that research supports the interventions you have selected and be open to better ways of addressing patient problems and issues. Always monitor the patient's responses to your interventions so that you can modify the plan of care if needed. The golden rule is assess, reassess, revise, and record. We're going to assess our patients before performing nursing actions. We're going to reassess them to determine what their response after you've performed any kind of an intervention. You're going to revise your approach if it's indicated, and then you're going to record the patient's responses and any changes you made in the care plan. So this slide talks about different types of nursing interventions, and we're going to talk about each of these on the following slides. So assisting with ADLs. Nurses assist patients with activities that people perform daily to promote comfort, health, and well-being. Many problems can interfere with a patient being able to do their own ADLs. These can be acute or chronic problems, temporary or permanent, and require teaching or assistance to help restore function. Examples include helping a debilitated patient eat, ambulating a patient after surgery, providing range of motion exercises, turning and positioning a bedbound patient, or administering an enema. Teaching is a very important nursing intervention. Nurses provide teaching in relation to cognitive, psychomotor, and affective domains. Examples of this include conducting a class about the signs and symptoms of hyperglycemia, or teaching a patient how to self-administer insulin. Nurses use clinical judgment to identify and respond to life-threatening changes in a patient's condition. The related interventions generally are associated with meeting a patient's basic physiologic need. Some example of this would be performing abdominal thrusts for a choking victim, implementing CPR, discontinuing a blood transfusion when a patient has clinical indicators of a transfusion reaction. Nurses provide interventions that assist people to maintain health and avoid health problems. They aim to help people at increased risk for illness. This increased risk can be because of developmental levels, such as neonates, young children, or older adults, or increased risk of negative consequences of their behaviors, such as people who smoke, drink alcohol excessively, abuse drugs, have multiple sex partners, or overeat. They also aim to help people limit exacerbations of illnesses and subsequent health problems as a result of an initial illness. Example of health promotion activities include administering vaccines, teaching a class about healthy nutrition, promoting smoking cessation or weight reduction, using standard precautions, or turning and positioning an immobile patient. Nurses must be able to competently perform technical psychomotor skills associated with the procedure. The nurses should know the steps, principles, rationales, and expected outcomes relative to nursing procedures to implement them in an appropriate situation safely. Examples of this including administering medications via various routes, suctioning a patient's respiratory tract, changing a wound dressing, or irrigating a colostomy. Nurses use therapeutic interviewing techniques to encourage patients to ventilate feelings and concerns. Once the nurse identifies a patient's emotional needs, the nurse continues to support the patient emotionally while exploring potential coping strategies. In addition, the nurse uses interpersonal interventions when working as an advocate for the patient, coordinating healthcare activities, and collaborating with others on the patient's behalf. Examples of this would be using non-directive interviewing techniques, gently addressing a patient's behavior, or collaborating with a patient to identify a goal. Nurses may delegate nursing care to unlicensed assistive personnel, licensed practical nurses, or other registered nurses. Things that can be delegated to a UAP include basic uncomplicated interventions. So this would be like bathing a bedbound patient, ambulating a stable postoperative patient, obtaining vital signs from patients who are stable. Things you can delegate to an LPN or LVN, routine nursing care for patients who are stable and whose care is uncomplicated. This would include administering medications, changing a dressing, instilling an enema. Things you can delegate to another registered nurse include complex nursing interventions. This would be like performing a physical assessment, teaching a patient how to self-administer insulin, formulating a patient's plan of care. The big thing about delegating is to make sure that the delegating is done appropriately. The delegation needs to ensure that the person implementing the care is legally permitted to provide the delegated care, is knowledgeable, and is able to deliver the care safely. The nurse that delegates the care is responsible for assuming responsibility for the care that is delegated and its consequences. We're responsible for delegating appropriately, ensuring that the care is implemented according to the standards of care, and then we evaluate the patient's response to the interventions that were implemented. Nurses communicate information to other members of the healthcare team. This helps provide continuity of care. This communication can be verbal or in writing. Written documentation also establishes a permanent legal record of the care provided and the patient's response. Examples of this communication and reporting include documenting vital signs on a flow sheet, describing a patient's skin integrity on a pressure ulcer scale, providing verbal report to the nurse arriving for the next shift, documenting medication administration and the patient's response to that medication. The big thing to remember is if an intervention is not documented, they are not considered done. Evaluation, or the fifth step of the nursing process, involves issues related to structure, process, and patient outcomes. The nurse first reassesses the patient to identify patient responses to the interventions or the actual outcomes. And then they compare those actual outcomes with the expected outcome to determine goal achievement. It is a continuous process that requires the plan of care to be modified as often as necessary, either during or after care. So there are 5 classic elements of evaluation. The first is identifying evaluative criteria and standards. So what are you looking for when you evaluate? So for example, what are the expected patient outcomes? We're going to be collecting data to determine whether these criteria and standards are met. And we're going to interpret and summarize our findings, document what our judgment is, and then decide if we're going to terminate, continue, or modify their plan of care. Nurses write outcomes during the planning phase of the nursing process. These outcomes are generally written to address one of 4 areas. This can be cognitive, psychomotor, affective, or physiologic. In addition to knowing what type of data to collect to determine an outcome achievement, the nurse needs to know when to collect the data. When the patient outcomes were developed, a time frame was established for determining whether or not the specified changes have been met. So remember back when we did our planning stage and we say, by discharge, by surgery, within 1 week, the patient will. Those are all time frames. So that gives us an idea when we need to start collecting our evaluation data. So I mentioned on the previous slide that when we write our outcomes during the planning phase, we're writing these outcomes to address 4 areas. So when we write our outcomes for these 4 areas, then we need to know what type of outcome data we're collecting. So if I'm writing an outcome for cognitive, we are looking for an increase in the patient's knowledge. So that's what we're going to be evaluating. For psychomotor, we're looking for the patient's achievements of a new skill. So can they use crutches, something along that lines. Affective, this is a change in the patient's values, beliefs, and attitudes. And then physiologic, we're looking for physiologic changes in the patient. So physical changes in the patient. So is their blood pressure decreased? Is their pulse decreased? Can they ambulate? That type of thing. So this slide just talks about some different ways that we can evaluate to those 4 areas. So when you're evaluating a cognitive outcome, we want to ask a patient to repeat information or apply their new knowledge. This could be like a teach-reteach situation. With psychomotor, we're going to ask the patient to demonstrate their new skill. The affective areas, we're going to have to observe. We're going to have to observe the patient's behavior and their conversation. Physiologic, we're going to use a physical assessment skill. So measure a blood pressure, count a pulse, count respirations, that type of thing, and then compare their data to their baseline. After the data have been collected and interpreted to determine patient outcome achievement, the nurse makes and documents judgment summarizing the findings. This is termed the evaluative statement. The 2-part evaluated statement includes a decision of how well the outcome was met, along with patient data or behaviors that support this decisions. Outcomes may have been met, partially met, or not met. Your book gives a really good example of this. So first example would be the outcomes met. And then the statement is, patient reports 1 week of no tobacco use. And then the nurse signs her name. Another example would be outcome partially met. Patient reports decreased tobacco use from 1 pack per day to 4 to 6 cigarettes per day. And then she makes a decision along with what we're going to do with our plans. So she states, continue to implement and monitor their plan. So this was partially met. They're decreased their tobacco use, but they haven't quit completely, if that was the goal. And then the last one is the outcome wasn't met at all. So patient reports no change in tobacco use. So then the nurse documents, okay, how am I going to revise my plan? So revision, re-explore patient's commitment to try tobacco use control strategies and adequacy of personal support systems to eliminate tobacco use. When evaluation reveals that the patient has made little or no progress toward an outcome achievement, the nurse needs to reevaluate each preceding step of the nursing process to try to identify the contributing factors causing problems with the care plan. New assessment data may need to be collected, diagnoses may need to be added or altered, outcomes may need to outcomes may need to be modified or rewritten, nursing orders may need to be changed, or evaluation may need to be targeted more frequently. After identifying the factors contributing to the outcomes not being achieved, use the evaluative statement to suggest necessary revisions to the plan, like we talked about in that previous slide. Revisions may include deleting or modifying the nursing diagnosis or problem, making the outcome statement more realistic, increasing the complexity of the outcome statement, or adjusting the time criteria in the outcome statement, or changing the nursing interventions.